So we are moving from, for example, to classify the T-cell lymphoma. It's very difficult because they are rare diseases representing around 10 to 15% of whole lymphoma worldwide. And they are very complex, heterogeneous, with more than 30 entities nowadays in the current WHO classification. So it makes the diagnosis difficult, and it still remains an unmet medical need in terms of therapy. So we have learned a lot, quite a lot, in the last years based on gene expression profiling and genome-wide studies. We know better now the cell of origin of many of these lymphoma. You know that the T-cell lymphoma, the immune system is quite complex with many T-cell subsets. And for example, we know that around 30 to 40% of all peripheral T-cell lymphoma are deriving from a specific subset of T helper cell, which is denominated the T follicular helper cell. These cells are normally located within the germinal centers of the B-cell follicles, and they provide normally help to B cells. And the lymphoma that are originating from this cell subtype are called TFH PTCL, and they include angioimmunoblastic T-cell lymphoma, an entity which has been reported in the past not as a lymphoma, but as a kind of disimmune condition due to the probably irritation of the B-cell system, which is provided by the origin of the cell, the function of the neoplastic cells. Now we know that other lymphoma that do not look like angioimmunoblastic T-cell lymphoma are also originating from this cell subset. They have a very unique gene signature with also a very unique mutational landscape with mutations combining alteration in the epigenetic modifiers such as TET2 or DNMT3, which can occur early in the ontogeny, and also mutations in signaling, especially ROE mutation, which is hotspot mutations in around 2/3 of patients, but also mutations in genes of the TCR signaling. And in addition, of course, we can have additional mutations in genes involved in cell cycle or apoptosis. As a consequence of this, we could use drugs targeting epigenetic modifiers such as DNA methylating, hypomethylating agents such as 5-ASA that may give a response to some patients, at least a good proportion of the patients according to recent studies. And maybe we should use the combinations of agents targeting epigenetic modifiers together with agents targeting more signaling pathways. Besides this TFH PTCL, which as I said represents 30 to 40% of all PTCL, there is a group of lymphoma which express CD30 at the membrane, which are almost called anaplastic large cell lymphoma. They appear to be heterogeneous in terms of genetic landscape, beside those having rearrangement of the ALK genes. This is the best delineated entity, which usually respond well to polychemotherapy. And there is a group of ALK-negative anaplastic large cell lymphoma, which appear more heterogeneous in terms of genetic landscape. Among this group, there is a group which is associated with just 22 rearrangements. It appears to constitute a specific biological subtypes with lack of STAT3 activations and or other features that may give rise to a specific biology and a specific outcome. Indeed, those lymphoma with just 22 rearrangements are doing well compared to other non-DUS 22 rearranged ALK-negative anaplastic large cell lymphoma. In this group of lymphoma, it's becoming more complex because around 1/3 of them, according to a recent publication during this year, have mutations involving a gene which is called muscarine that may play a role in the CD30 IR4 MYC axis and provide proliferation to the cells. So that means that from a unique concept of a neoplasm which appear to be composed of large cells expressing CD30, we have now, depending on the genetic landscape, different subtypes that can be either targeted for therapy by similar compounds, such as, BV targeting CD30 at the surface of the cells, or targeting specifically subsets, such as tyrosine kinase with crizotinib for those having ALK rearrangements, or maybe other inhibitors such as BET inhibitors for those having these mutations in muscling in the DUS22 rearranged ALK-negative anaplastic large cell lymphoma. Finally, if I could add something of this group of ALK-negative anaplastic large cell lymphoma, depending on the clinical presentation, there is a small subset that has been recognized in the last, I would say, 10 years, which involves lymphoma occurring adjacent to breast implant, which are referred as breast implant-associated anaplastic large cell lymphoma. These lymphoma usually occur after a long latency, after an implant has been given either for cosmetic or for reconstruction, and they appear to constitute a very specific entity in which the role of chronal inflammation is certainly important at the early step of the disease, and then we have shown in a study which is not yet completely published that the cells that proliferate, that are still probably polyclonal or oligoclonal, will acquire somatic mutations in either epigenetic regulators and also in a gene of the JAK-STAT pathway, such as STAT3, STAT5B, or JAK1. So it appears that an accumulation of the proliferation of the neoplastic cells is due to the accumulation of cytokine in a very enclosed environment, and then favor the occurrence of somatic mutation that brings an autonomous proliferation. Hopefully, this lymphoma has so far a relatively good prognosis, except in the form that are characterized by a tumor mass, which will require systemic therapy with either chemotherapy and or brentuximab vedotin therapy. So besides, I said that there were more than 30 entities. So there remains a lot of entities, and among these, there are entities that are derived from cells of the innate immune system, such as NK cells or gamma delta T cells, or different subsets of alpha beta T cells. These lymphoma are usually rare. They share in common to have an extranodal presentation. They include, for example, hepatosplenic T-cell lymphoma, enteropathy-associated T-cell lymphoma, monomorphic epitheliotropic T-cell lymphoma, and they will usually show plasticity in terms of cell of origin, with some cases, and also extranodal NK T-cell lymphoma, which are associated with EBV and are more prevalent in Asia and in, I would say, in Latin America. So they share in common extranodal presentation, derivation from subset of cytotoxic cells, and also acquired mutation in JAK-STAT pathway genes, as well as frequently mutations in methyltransferase, such as the SETD2 gene, which is often deleted and in this lymphoma or mutated in this lymphoma and bring a loss of function mutations. SETD2 is considered now as a tumor suppressor gene. As a consequence, we may have also new targets in order to make a correct diagnosis, but also new targets for therapies in those lymphoma. However, so far, I would say to conclude that the gold standard for treating those patients still remains anthracycline-based chemotherapy, which are efficient in only a proportion of the patients and with an overall survival of around 30 to 40%, with some exceptions, because I said that there is huge heterogeneity in this lymphoma and there are hopefully a few subgroups which have a good outcome, such as, for example, ALK-positive anaplastic large cell lymphoma. However, for the majority of them, they remain an unmet medical need, but I try to convince you that, first of all, we have now opportunities to better diagnose this lymphoma, which are complex. We have markers that we can use either at the immunohistochemical level or at the molecular level for diagnosis in the routine, this lymphoma, and also give opportunities to better treat and to offer these patients more precise targeted therapies.